I welcome to all our students of third first MBBS who are ready to listen to surgery lecture today. I am Dr. Vyas, Professor of Surgery in Rural Medical College, Loni. At the outset, let me express my gratitude to Dean, Rural Medical College and HOD Surgery for providing me this opportunity and this platform to talk to you. We are facing unprecedented challenges due to COVID-19. As you all know, any adversity throws an opportunity to innovate and chances to overcome the challenges. Determination and continuity of efforts are required. This mode of e-learning is an attempt to overcome the problem of closure of educational institutions and social distancing required to check the spread of COVID-19. I take this opportunity to talk to you on the subject of injuries to the chest. This is covered in two lectures. The first one is taken up now. Our aim or learning principle in the in this lecture is to describe the, the various forms of chest injuries in the context of clinical presentation, investigations in a case of chest trauma, and complications and management of chest trauma, including ATLS. We our we will also learn that the management of trauma is based on physiology as well as the anatomy. We will also learn the gross and the surgical anatomy of the chest and abdomen. The use of special investigations and their limitations in the investigation of a case of chest trauma will also be assessed. If you see this, you will understand that these aspects of chest injury, components of chest trauma, clinical features of each component, describe complications of chest trauma and their management, they are considered as cognitive in the cognitive domain, and an MBBS student is expected to know all these aspects. This pie diagram shows that the commonest cause of death in trauma is due to head injury. This constitutes about 42%. In 40% of cases, bleeding or hemorrhage is the cause of death in trauma cases. And in another 6%, trauma contributes immensely to the cause of death. In nutshell, about 40% cases of trauma they have contribute to the mortality in trauma. We need to keep in mind that the injury does not respect the clinical anatomical boundaries. The torso is that part of body which contains the chest, abdomen, and the pelvis. It does not include head, neck, arms, and legs. About 40% of all deaths in trauma are from head injury, and the causes of death in hemorrhages in majority cases is in the chest injury, hemorrhage is the cause of death. Now, studying the causes of early death in trauma cases, there are three more important factors. One is hypoxia from any cause, where the oxygen supply is in the blood is less, and hypovolemia due to blood loss and tamponade. A physician who is not suspicious of these and does not give the first priority in mitigating these shall lose his patient regardless of exact nature of the injuries. Now, as we have understood that hemorrhage is the common cause, in most of the cases, is the cause of death from in trauma. The causes of hemorrhage are recognized in 5 major places. We call it one on the floor and 4 more. That means one on the floor means it is external bleeding, which is visible on the side. The blood which is lost and is visible on the outside is the one cause of hemorrhage, is sites of hemorrhage, major hemorrhage. Then we have got chest, then we have got abdomen, including the retroperitoneum, pelvis, and extremities. They are considered 5 major sites of hemorrhage. We call them in this way to remember mnemonic is one on the floor and 4. Now, whenever we are treating a case of trauma, whatever the system or the organ or the region is involved, we have to keep in mind ATLS principle of resuscitation, Advanced Trauma Life Support. This was introduced by American College of Surgeons, and there are priorities. According to ATLS, there are priorities in the management of severe trauma. These are covered in ATS principles, and the ATLS principle is to be observed strictly before organ or a region-specific management for trauma is contemplated. And these ATS principles of resuscitation in case of trauma are airway, A for airway, B for breathing, C for circulation, and then D for disability, and E for environmental exposure. So these principles are to be attended in the manner in which they are depicted here. The first priority is airway. Airway has to be cleared and maintained at all costs. Then comes the breathing, and then comes the circulation. The key to a good outcome is early physical resuscitation followed by a correct diagnosis. Now, in chest injuries, there are 6 elements or 6 types of chest injuries. 6 of them are immediate life-threatening, and the remaining 6 are potentially life-threatening. So, first 6, which are immediately life-threatening, should be sought for and managed during the primary survey. The potentially life-threatening can be detected during the secondary survey. During the assessment of the person and the primary survey, a high index of suspicion must be maintained to diagnose the potential threats to life, as their symptom signs can be very subtle or mild. Now, these deadly dozen chest injuries are this way. There 6 of them are immediate life-threatening and 6 are potentially life-threatening. First, in the immediate life-threatening is airway. The maintenance of a clear and a clean airway is very important. If there are neck hematoma, which can particularly cause an airway edema, airway maintenance becomes very difficult. So an early intubation can be considered, because later on it may be very difficult to put the tube. The second immediately life-threatening injury is tension pneumothorax. A tension pneumothorax develops when a one-way wall air leak occurs, either from the lung or through the chest wall. Air is sucked into the thoracic cavity without any means of escape, completely collapsing, then compressing the affected lung. The mediastinum is displaced to the opposite side, decreasing the venous return and compressing the opposite lung. Tension pneumothorax is a clinical diagnosis, and treatment should never be delayed by waiting for radiological confirmation. Treatment consists of immediate decompression, initially by rapid insertion of a large bore cannula into the second intercostal space in the mid-clavicle line of the affected side, then followed by insertion of chest tube through the fifth intercostal space in the anterior axillary line. Then there is a pericardial component. Any injury can cause a bleeding trauma to the heart, and blood may be collected. This is a very small potential space, and a small collection of blood is likely to affect the working of the heart. If there is a patient in a shock and there is a ECG abnormalities, it should be suspected. The next is an open pneumothorax. This is due to a large defect in the chest, leading to immediate equilibration between the intrathoracic and atmospheric pressure. If the opening in the chest wall exceeds about 2/3 of the diameter of trachea, then with each inspiratory cycle, it will be potentially drawn through the defect rather than through the trachea. Air accumulates in the hemithorax rather than in the lung, and with each aspiration leading to profound hypoventilation on the affected side and hypoxia. There can be the massive haemothorax. In blunt injury, the bleeding comes from the torn intercostal vessels and occasionally from the internal memory artery. Secondary to fractures of the ribs causes massive hemothorax penetrative injury, a variety of viscera, both thoracic and abdominal, with blood leaking through the hole in the diaphragm from the positive pressure abdomen into the negative pressure may be involved. Accumulation of blood in the hemithorax can significantly compromise respiratory efforts, compressing the lungs and preventing adequate ventilation. The massive hemothorax presents with hemorrhagic shock, flat neck veins, unilateral absence of breath sounds, and dullness supervision. The initial treatment consists of correcting the hypomolic shock, insertion of an intercostal drain, and in some cases intubation. Initial drainage of more than 1,500 ml of blood or ongoing hemorrhage of more than 200 ml per hour over 3 to 4 hours is generally considered an indication for thoracotomy. The flail chest. This condition usually results from blunt trauma associated with multiple rib fractures and is defined as 3 or more ribs fractured in 2 or more places. The blunt force typically also produces an underlying pulmonary contusion. The diagnosis is made clinically in patients who are not ventilated, not by radiography. To confirm the diagnosis, the chest wall can be observed for paradoxical motion of chest wall segment. The component of chest trauma are chest wall and pleura and lungs. The second group is mediastinum, and third is injury to the heart and pericardium. In the chest wall, pleura, lungs, there can be fracture ribs, fracture sternum. There can be surgical emphysema. There can be pneumothorax, open, close, and tension. The tension outline of tension we have already got the preliminary. Then stove chest, flail chest, hemothorax, contusion lungs. In the mediastinal chest injury component, we can have rupture of diaphragm and mediastinal emphysema. In injury to the heart and pericardium, there can be myocardial contusion and pericardial tamponade. The fracture of ribs is a commonest injury. Ribs are fractured very commonly. First and the second ribs are rarely fractured because they are protected by clavicle. 11 and 12 ribs are also rarely fractured because they are floating, they give way. Now, ribs can be fractured by a direct trauma, by a crushing injury where they are fractured away from the site of impact. There can be a steering wheel injury, and rarely from a strong paroxysm cough can fracture ribs. You can see in the diagram there the rib is fractured. Now, what are the clinical features of fracture ribs? The most common feature is pain. When there is a fracture, there will be a pain. This pain is exaggerated during breathing, sneezing, and coughing. There can be a bruising at the local site. There can be local bony irregularity, which is very uncommon, but it can happen. And then there is a tenderness. If you touch that part, there will be pain. Then, when you put your palm on the fracture site, there will be capitus. You can feel that there is some abnormal movement. The bone fragments when they rub against each other, a special sound is produced. Then if you do a compression test, this may be positive. In the compression test, the compression of the chest is done by pushing the sternum posteriorly, and the pain will be felt at the site of fracture. The X-rays, plain X-rays can be used to confirm the fracture site, but the exposure for X-ray of the ribs is different than for the X-ray chest. The treatment of fracture rib is the relief of pain. It could be oral by tablets or by injection if the pain is severe. Intercostal nerve blocks, the above and below the fracture ribs, can be given by using the xylocaine in proper concentration and doses. Striking to the chest, which used to be done, it can still be done. It includes two ribs above and below the fracture ribs, and the step must cross the midline both anteriorly and posteriorly. The complications of fracture rib. Most of the rib, which isolated fractures of the ribs, they do not produce any complications, but they are known to produce complications when they are associated with other injuries or fracture ribs causing other injuries. First is shock. If there is hemorrhage and the multiple ribs are fractured, and there can be shock. There can be surgical emphysema, which is filling the air in the subcutaneous tissues. Then there can be traumatic pneumothorax, hemothorax, stay in chest, and they have got a failed chest, pulmonary contusion and laceration, injury to the heart and pericardium, traumatic asphyxia, and injury to the abdominal organs. These all can occur as a result of fracture of the ribs. Now, the first rib fracture is rare, as it is well protected. But when it fractures, it is understood that the traumatic force must be massive, and a traumatic massive force is likely to have associated injuries of vessels and neck. It has got a higher mortality of 30%. The fracture of sternum due to steering wheel or seat belt injury, the sternum can be injured. It's a very strong bone, but the trauma, if it is severe, can involve. Usually the external plate is involved, and if the sternum is injured, chances of myocardial damage are there. So it requires hospitalization, ECG monitoring, analgesia, and nasal. The treatment is usually conservative, but if the sternum fracture is unstable, you have to do active surgical management to stabilize the sternum. Surgical emphysema is air in the subcutaneous tissues. The fractured ends of the ribs injure the underlying length, and air comes out into the muscle and subcutaneous tissue. The crackling sound, which feeling which you get when the palm is placed over the site of surgical emphysema is unique, and once an experience is taken there, it is remembered for whole life. Clinical features of fracture ribs are pain in the chest, swelling. The surgical emphysema may extend into the neck or upper limb of the corresponding site, and there is a typical crepitus, which I said. Other causes of surgical emphysema, not only the ribs, but other organ injuries like descending colon, rectum, ruptured esophagus, and bronchus can cause surgical emphysema. So also the fracture of perineal sinuses and thoracic and abdominal incision can also cause sometimes. You can see the surgical emphysema here under the skin. You can easily see. The treatment of surgical emphysema is conservative, as usually air is absorbed from the subcutaneous tissues. Underwater sealed drainage, if it is associated with pneumothorax, can be done. Now, traumatic pneumothorax. Pneumothorax is air in the pleural cavity. Traumatic pneumothorax. A pneumothorax is air in the pleural cavity. When the blood also is associated with the air, it is called hemopneumothorax. We recognize three types of pneumothorax: closed, open, and tension pneumothorax. Now you can see here in the diagram, in the closed thorax, pneumothorax, the air collects in the pleural cavity. There is no communication with the outside. Depending on the size of the pneumothorax, the lung may be collapsed. In the open pneumothorax, there is a communication of the pleural cavity with the exterior, with the result that the pleural cavity cannot have a negative pressure. Therefore, the lung is collapsed and the air which comes out during this pressure inside the pleural cavity collects in the pleural cavity, not in the lung, and goes back. Since the atmospheric pressure is equal, the air from the trachea will not be able to come to the lung. The tension pneumothorax, there is a leakage, and the whole mechanism is there, and the air collects in pneumothorax, and it keeps on collecting. The result here is disastrous, as it with every respiration, act of inspiration, the air pressure is increasing. It does not only collapses the affected lung, affected side of the lung, but it has got an effect in the mediastinum, which is pushed to the upper side, and it can affect the other lung also. You can compare here. In the closed pneumothorax, the pleural tier is sealed, and pleural pressure is equal to the atmosphere, is higher than the atmospheric pressure. In open pneumothorax, there is a pleural tier is open, and the atmospheric pressure is equal to the pleural pressure. In tension pneumothorax, there is a ball and valve mechanism. Therefore, the pleural pressure is higher than the atmospheric pressure. In the closed pneumothorax, there is air in the pleural cavity, and due to small flow, and this is from the small closed rent in the lung. You can see, depending on the size, the lung is collapsed and cannot participate in gases excess. The treatment of closed pneumothorax, the air, if it is small, it can be steadily absorbed, and lungs subsequently re-expand by themselves. If there is a wound in the chest wall, it has to be closed. In the open pneumothorax, air may enter the pleural cavity through a wound in the chest wall. This defect, open defect, must be more than 3 centimeters. This will lead to immediate equilibration between the intrathoracic and atmospheric pressure. If the opening in the chest wall exceeds about 2/3 of the diaphragm trachea, then with each inspiratory cycle, the air will be preferably drawn through the defect rather than through the trachea. If the opening is small, then it cannot compete. The hole cannot compete, and the air might come through the trachea. Although the obstruction or bypass will depend on the size of the hole. The air accumulates in the hemithorax rather than in the lung, and with each expression leading to profound hypoventilation on the affected side and hypoxia. You can see the hole in the chest wall allows the air to come from here in the pleural cavity, and the lung collapses, and whatever air is there, it goes to the other side rather than the air coming from the trachea. The management of an open pneumothorax is converting into a closed pneumothorax. Instead of closing, we should put close the defect with an occlusive plastic dressing, which is taped on 3 sides, so that a flutter type valve is created and the air from outside cannot go into the pleural cavity. A chest tube can be inserted at a site remote from the injury site. A tension pneumothorax. Here, a lacerated lung communicates with a branch of the bronchial tree. You can see this here. There is a wall mechanism, leak, which has got a valve, so that air can come to the pleural cavity but cannot escape. And this is with each act of inspiration, the air increases the collection of air and the pressure increases. So this becomes a medical emergency. It will push the mediastinum and it will collapse not only the affected lung but the other lung as well. Because of this wall. The most common causes are penetrating chest trauma, blunt chest trauma with a pericardial lung injury, and air leak that did not spontaneously close, or iatrogenic lung injury, which is nowadays most common in ICU due to sentinel veins puncture and mechanical positive pressure ventilation. Yeah. Another way to express how this tension pneumothorax develops. Clinical features of tension pneumothorax include dyspnea, pain, shock, and cyanosis. A chest on percussion will be hyporesonant, and on auscultation there will be abscess of breath sounds, there will be shift of trachea, and apex beat towards will be shifted to the opposite side. Management of tension pneumothorax. It involves reducing the pressure in the pleural space, needle compression in the field, a whiteboard needle inserted in the pleural cavity through the second intercostal space at field site, followed by later on by intercostcutaneous. The capping of the open pneumothorax in case of penetrating injury. Traumatic pneumothorax. Accumulation of blood in the pleural cavity due to trauma in the chest. In case of blunt injury, there is bleeding from the torn intercostal vessels. In some cases, bleeding from the internal memory artery secondary to fracture of the ribs can also cause MS pneumothorax. In penetrating injury, a variety of viscera, both thoracic and abdominal, with blood leaking through a hole in the diaphragm from the positive pressure of the abdomen into the negative pressure thorax may be involved. Accumulation of blood in a hemothorax can significantly overcome respiratory efforts, compressing the lung and preventing adequate ventilation. The presentation of case of massive pneumothorax is with hemorrhagic shock, flat neck veins, and unilateral absence of blood pumps and dullness due to percussion. Treatment consists of correcting the hypovolemic shock, insertion of an intercostal drain, and in some cases, intubation. Initial drainage of more than 1,500 ml of blood in or ongoing hemorrhage of more than 200 ml per hour or 3 to 4 hours is generally considered an indication for urgent thoracotomy. Blood in the pleural space should be removed as completely and rapidly as possible to prevent ongoing bleeding and emphyema or fibrothorax later. Clamping a chest valve to tamponade a massive pneumothorax is not helpful. Clinical features. A case of hemothorax will have dullness on percussion, there will be weak dull breath sounds and impaired vocal resonance and shifting of the apex beat to the opposite side. In summary, chest injury is one of the common causes of morbidity and mortality. It's a common emergency and casualty case. Pneumothorax and hemothorax are mostly seen. It requires prompt diagnosis. Chest injury case requires a prompt diagnosis and intervention if required. Tube thoracotomy is usually required, and the early management is based on ATLS protocol. The references is Bailey and Lau, Short Practice of Surgery, 27th edition, and other. Thank you very much for your attention. I welcome to all our students of third first MBBS who are today ready to listen to our lectures. I am Dr. Vyas, Professor of Surgery. I thank the Dean and HOD Surgery for providing me this platform to interact with you. The mode of e-learning is an attempt to overcome the problem of closure of educational institutions and social distancing required to check the spread of coronavirus-19. I take this opportunity to talk to you on subject of injuries to the chest wall. This is covered in 2 lectures. The first one was covered in the last lecture, and we did with the special nature of where we dealt with special nature of chest trauma and the importance of understanding anatomy as well as physiology in chest trauma. We also dealt with the importance of following ATS protocols for engaging to deal with a case organ before engaging to deal with organ or region specific trauma. we discuss priorities in chest trauma and immediate life-threatening and potentially life-threatening chest injuries and priorities they deserve in management. Today we shall discuss the second part of injuries of the chest. Frail chest is defined as 3 or more rib fracture in 2 or more places. The blunt force typically produces an underlying pulmonary contusion. The diagnosis is made clinically in patients who are not ventilated. It is not made by radiography. On inspiration, the loose segment of chest wall is displaced inwards. Normally the chest moves outwards. But here, the loose segment of the chest wall is displaced inwards and therefore less air moves into the lungs. On expiration, the segment moves outwards. This movement is paradoxical and this type of respiration is called paradoxical respiration. Voluntary splitting of the chest wall occurs as a result of pain. So mechanically impaired chest wall movement and associated lung contusion will contribute to hypoxia. There is a high risk of developing a pneumothorax or haemothorax. You can see the multiple ribs are fractured. To confirm the diagnosis, there has to be a paradoxical respiration and on where the movement of the piece is opposite of what happens normally. The CT scan with contrast to display the vascular structure in the 3D direction of chest wall is a gold standard for diagnosis of this condition. Traditionally, mechanical ventilators were used to internally splint the chest, but had a price in terms of intensive care unit resources and ventilation dependent morbidity. Currently, the treatment failed chest consists of oxygen administration, adequate analgesia, and physiotherapy. If a chest tube is in situ, topical intrapleural local analgesia introduced via the tube can also be used. Artificial ventilation is required for cases developing respiratory failure, despite adequate analgesia and oxygen. Surgery to stabilize the frail segment using internal fixation of the rib may be useful in some patients with isolated or severe chest injury and pulmonary contusion. The old method is interaxional fixation of chest wall using the prongs and the hooks so that it can be elevated. This is no longer done. The treatment is to make all cases they do not require the splitties. Currently the treatment is oxygen administration, adequate analgesia and physiotherapy. Artificial ventilation is reserved for cases developing respiratory failure despite adequate analgesia and mechanical ventilation to internal split. But for this patient has to be paralyzed in intensive care unit and it carries a ventilation dependent mode. The treatment therefore in summary is immediate hospitalization, passage of an endocardial tube, insertion of an endocostal drain and mechanical or manual control of ventilation. Fixation of aortic segment, surgery to stabilize the frail segment using internal fixation of the ribs may be useful in patients with isolated or severe chest injury with pulmonary contusion. Stroke in chest. This type it has got a multiple rib fractures and there is a depression of the chest. The fracture segments which are multiple fractured are driven in and this results in accumulation of pulmonary sickness. Now, pulmonary contusion. Pulmonary contusion occurs more frequently following a blunt trauma, usually associated with the failed segment and fractured ribs. This is very common, potentially lethal injury and a major cause of hypoxemia after blunt trauma. Following gunshot wounds, there is an area of contusion from the shock wave of the bullet. Hemoptysis or blood in the endocardial tube is a sign of pulmonary contusion. Natural progression of pulmonary contusion is worsening hypoxia for the first 24 to 48 hours. In the X-ray film, there is a fluffy infiltrate in the contused lung. The contusion generally results in areas of consolidation. On follow-up, intra-alveolar and interstitial hemorrhage, edema, fluid obstruction of airways, and leukocyte infiltration. In mild contusion, the treatment is oxygen administration, pulmonary toilet, and adequate analgesia. In more severe cases, mechanical ventilation becomes necessary. Normovolemia is critical for adequate tissue perfusion, and fluid restriction is not advised. The mediastinal injuries. The zone overlying the mediastinum with major air cells and the heart is also an extremely high risk area for penetrating wounds. Any wound in this region should immediately raise the suspicion of major vascular or an associated cardiac injury, even in the absence of gross physical signs. Now, mediastinal emphysema is escape of air into the mediastinum. It could be as a result of injury to the trachea, bronchi, or even esophagus. It is first revealed at thorax. It is a life-threatening. The treatment is thoracotomy and repair of wound or air through which the air is coming out. Diaphragmatic injuries. Blunt injury to diaphragm is usually caused by a compressive force applied to the pelvis and abdomen. Diaphragm rupture is usually large, with herniation of abdominal contents into the chest. Any penetrating injury to the lower half of the chest may therefore have penetrated the diaphragm and enter the abdomen. Injury to this zone should be investigated as if both cavities had been penetrated. Herniation of stomach, spleen, left tonsillosus, or omentum and liver is common. Most diaphragmatic injuries are silent, and the presenting features are those of injury to the surrounding organs. On auscultation or test, the bone sounds are heard, which is uncommon. That indicates that the bones have come to migrated to the chest cavity along with their blood supply. Chest radiography after placement of nasogastric tube may be helpful. This may show stomach herniating into the chest. Contrast series of upper and lower gastrointestinal tract, CT scan and diagnosed petal lavage, all lack positive or negative predictive value. Most accurate evaluation is by video assisted thoracoscopy or laparoscopy. The latter offering the advantage of allowing the surgeon to proceed to repair and additional revolution of the abdominal organs. Traumatic rupture of the diaphragm. X-ray hollow viscera containing air in the pleural cavity. X-rays will show the hollow viscera containing air. Diagnosis of diaphragmatic rupture can be easily missed in the acute phase. It may only be discovered at operation or through the presentation of complications. Treatment of diaphragmatic hernia is thoracotomy if it is compromising with the rest, and herniated viscera are put back into the abdomen. The diaphragm is suture repaired. Operative repair is recommended in all cases. All penetrating diaphragmatic injury, hollow viscous injury should be ruled out, and repair should be done from the abdomen. Injury to the heart and pericardium. Due to penetrating wounds, they result in cardiac tamponade. The diminution of cardiac sound, increased area of cardiac dullness, steady fall of arterial pressure with gradual rise of venous pressure are the signs which we expect. Now, potentially life-threatening injuries. Thoracic aortic disruption. This is due to deceleration injury. 15% survive to reach hospital. Usually distal to the ligamentum teresum, there is a disruption. Features of the intrascapular pain, murmurs, hoarseness, gross asymmetry in the system blood pressure due to connection between the upper and lower limbs. There will be a gross asymmetry, widened blood pressure and chest wall condition. Chest X-ray, mediastinal widening, confirmed by a CT scan of the mediastinum and possibly by transesophageal electromyography. Urgent exploration and repair, placing an endovascular intra-aortic stent and diet operated repair of the repair axial grafting using a dent graft is the procedure recommended. And see the thoracic aortic disruption. Myocardial contusion, significant blunt cardiac injury that causes hemodynamic instability is rare. Blunt myocardial injury should be suspected in any patient sustaining blunt trauma who develops early ECG abnormalities. Two-dimensional echocardiography may show wall motion abnormalities. A transesophageal electrogram may also be helpful. There is very little evidence that enzyme stabilizations have any place in diagnosis. All patients with myocardial contusion diagnosed with conduction abnormalities are at risk of developing sudden arrhythmias and should be closely monitored. Pericardial tamponade. The pericardial tamponade results from penetrating trauma. Accumulation of relatively small amount of blood into the non-distendable pericardial tract can produce compression of the heart and obstruction of the venous return, thus leading to decreased filling of the cardiac chambers during diastole. All patients with penetrating injury anywhere near the heart plus shock must be considered for a cardiac injury until proved otherwise. The clinical presentation is dynamic. The patient is increasing restless with tachypnea, dyspnea, and distended neck veins. Classically, the presentation consists of central venous pressure elevation, decline in artery pressure with tachycardia, and muffled heart sounds. However, in case in which major bleeding from the other sides have taken place, the neck vein may be flat. A high index of suspicion and further diagnostic investigation will be needed to make the diagnosis of those cases which are not clinically obvious. These include E-FAST, showing fluid in the pericardial sac. This is most expeditious and reliable diagnosis. Or a chest graphy looking for enlarged heart shadow. CCT, if the patient is stable, can be diagnosed. A central line should be, as a treatment, central line should be placed, checking for rising venous pressure. Needle pericardiocentesis has been suggested. However, in penetrating injury to the heart, there is usually a substantial clot in the pericardium, which may prevent aspiration. A dry pericardiocentesis proves that only there is a clot on both ends of the person. It has a high potential for iatrogenic injury to the heart and should at the most be regarded as a desperate among temporary measures in transport situation. The correct immediate treatment of tamponade is only operative, either via subxiphoid window or by open surgery, sternotomy or duct with repair of the heart in the theatre. Tracheobronchial injuries. Severe subcutaneous emphysema with respiratory compromise can suggest tracheobronchial disruption. Chest drain placed on the upper side will reveal a large air bleed and a closed lung may fail to re-expand. Bronchoscopic is diagnostic. Treatment involves intubation of the affected bronchus followed by operative repair. Esophageal injuries. They result from penetrating trauma. Blunt injury is rare. High index of suspicion is required. A patient can present with odynophagia, pain on swallowing saliva, food, or liquid. Subcutaneous or medial emphysema, full effusion, air in the periesophageal space, and unexplained fever. Mediastinal and deep cerebral emphysema are evidence of an aerodigestive injury until proved otherwise. The mortality rate rises exponentially if treatment is delayed. A combination of esophagogram in the decubitus position and esophagostomy confirms diagnosis in great majority of cases. The treatment is operative repair or any defect and drainage. Traumatic cardiothorax results from the trauma to the thoracic duct. It occurs in rib fractures, brain trauma, operation on the base of the neck. Radiologic appearance is almost that of a pleural effusion. The treatment is repeated aspiration, respiratory fluid intake, fat-free diet, right-sided thoracotomy if no response, closure with underwater seal treatments. Critical physiology. It is very clear that resuscitation of all injuries to the chest and abdomen should follow traditional ATLS principles. Bleeding is a major problem. This may be obvious at the time of evaluation. However, a young physically fit individual bleeding may only produce subtle changes in vital measures and therefore be difficult to assess. Although obvious injury may be present, traditional indicators are unreliable. Clinical indications of a potentially ongoing bleeding in chest trauma. There are certain indications which indicate that the bleeding is still going on. Some of them are anatomical and some of them are physiological. In physiological, there is an increasing respiratory rate, there is an increasing pulse rate, falling blood pressure, and rising serum lactate. Then anatomical indicators. There is visible bleeding, injury in close proximity to the basal vessels, and penetrating injury with a retained mesial are the indicators for ongoing bleeding chest trauma. Investigation of chest injury in a casualty is based on clinical examination, E-FAST, and supplemented by chest radiography. Ultrasound, extended focus assessment with sonar for trauma. Ultrasound can usually differentiate between contusion and actual presence of blood. Extended focus assessment with sonar for trauma is becoming the most common investigation. This technique uses sonar assessment in the chest, looking for a cardiac tamponade or free air and blood in the pneumothorax on each side. Assessment for blood in the abdominal cavity, in the pericardium, and in the subrahmanic spaces. Underwater chest drain. In a physiologically gross unstable patient where physical examination is inconclusive, there is no time for radiological investigation. Insertion of an underwater chest drainage tube is a diagnostic as well as therapeutic procedure, and the insertion benefits of insertion far outweigh the risk involved in such cases. Chest radiograph in a hemodynamically unstable or spine at risk is an intravascular chest graph with simplest initial investigation and will provide good information regarding skeletal deviation, lung animation pathology as well as skeletal injury. In penetrating injury, it may be more helpful for the radiography to be performed with the patient position erect, as this will best reveal a small pneumothorax, a fluid meniscus, or air fluid level in the presence of free gas on the diaphragm. Up to 300 ml of blood may pool behind the domes of diaphragm and may not be visible even in an erect view. You can see the X-rays showing the component of the chest trauma. The presence of thoracic injury should alert the physician to the possibility of adjacent thoracic or abdominal injury. Rupture of thoracic aorta can be related to structures of the first and second rib. Bilateral clavicle fracture and fracture of the sternum and thoracic spine. Fracture of the lower ribs can be related to injury of liver and spleen. Fracture of the ribs, irrespective site, can be related to injury to the lung parenchyma or thoracic valve vasculature, causing haemothorax, pneumothorax, and lung condition. CT scan with contrast allows for three-dimensional reconstruction of chest and abdomen, as well as the body skeleton. It has become the principal and the most reliable examination for major injury in thoracic trauma. In blunt chest trauma, the CT scan will allow the definition of fractures as well as showing hematomas, pneumothoraces, and pulmonary contusion. In penetrating trauma, the scan may show the track or presence of missile and allow the proper planning of definition. However, although the presence of isolated rupture of diaphragm, you can see here the CT scan will be showing aortic dissection on a two-dimension. In penetrating injury, most patients who have suffered injury to the chest can be managed with appropriate resuscitation and insertion of the intercostal tube. If a sucking chest wound is present, this should not be fully closed, but should be covered with a piece of plastic closed on three sides to form a one-way wall, and thereafter an underwater chest should be removed from the wound. No attempt should be made to close the sucking chest wound until controlled drainage has been achieved. Laxis converts a stable patient with an open thorax into an unstable patient with a tension pneumothorax. In blunt injury, most bleeding points occur from the intercostal or internal mammary vessels, and it is relatively rare for those to require surgery. If bleeding does not stop immediately, the vessel can be tied off eventually. In blunt chest compressive injuries, particularly in the presence of a flail chest, there can be a certain lung contusion. The patient in extremes with external chest hemorrhage will require emergency therapy. In the closed management of chest injury, about 80% of chest injuries can be managed with the insertion of an intragastrointestinal drain only. Do not close a sucking chest wound until the drain is in place. If the bleeding persists, the chest valve will need to be opened and direct thermostat control is required. Inserting and managing a chest drain. A chest drain insertion is both diagnostic as well as therapeutic in a case of chest injury. An intercostal tube connected to underwater seal is central to the management of chest diseases. The site where the tube can is called triangle of safety. It is anterior to the mid-axillary line, it is above the level of nipple, and below the and lateral to the pectoralis major muscle. This usually is in the fifth intercostal space. Technique. The meticulous attention to sterility is required. Adequate local anesthesia, which include pura. Third, dissection to cut up to the skin only. The blood dissection thereafter of the artiforceps down to the muscle layer. This should only be the stated anterior intercostal. An oblique track, so the skin incision and the hole in the parietal pura do not level each other, and the drain is in a short tunnel, which reduces chances of entering air. A drain for a pneumothorax should aim towards the apex of the lung, and a drain for the fluid diffusion hemorrhage should be aimed nearer the base. You can see the chest tube, and then it is put in the underwater seal. The drain should pass over the upper edge of the rib to avoid the neovascular bundle that lies beneath the rib. The draining system should be secured but do not obliterate the drain. After completion, check that the drain has achieved its objective by taking a chest sonograph. It is preferred not to apply suction to the drain or to clamp it. The danger is that the clamp may be applied for transport and forgotten. The dangers of disconnection and siphoning are small and are best averted in other ways apart from clamping. Removed drain vent is no longer has got a function. Suction mechanism, you can see we need to apply the system to it. In summary, chest injury is one of the common causes of morbidity and mortality. Common emergency and casualty case. It's a common. Pneumothorax and haemothorax are mostly seen. Requires prompt diagnosis and intervention if required. Just recommend is usually critical. Management is based on ATLS principle. The reference is 11 billion love short practice study 27th edition and others. Thanks for your attention. Thank you for listening. Thank you very much. This covers our chest.